So
All right, so we're recording. Thank you all for being here. I really appreciate you coming to see our lunchtime presentation for August. We've been doing, for many of you that have tuned in, we've been doing monthly lunchtime presentations to celebrate Scripps 100 years. And I put in the chat the link to our centennial celebration, which is September 9th and 10th. Registration has closed, but if there's someone that absolutely needs to come, wants to come, like, please let us know. But we're hoping folks can come out and see the scheduled events that we have planned. So that's there in the chat. And just to, I think I know everyone on here. So I'm Leah Jansen, Assistant Director for Academic Programs and Research Support. Thank you all for being here again. I want to welcome an alumna, Dr. Jacquelyn Dantis. Thank you for being here. So her presentation is No Easy Answer to Nursing Shortage, an autoethnography of a CNA job. Jacquelyn holds a master's degree in sociology with a core concentration in gerontology from Roosevelt University and is currently working on completing a certificate in long-term care. She finished the PhD program in 2014, and she's worked at Lewis University in Chicago State as a lecturer and advisor. She's taught successfully in the areas of women's studies, gerontology, and sociology, which focuses on diversity and social inequalities. Her research also focuses on diversity, gender, racial and health inequality, long-term care, and workplace disparities. So, Jacquelyn, we're going to pass it over to you, and you should be able to share your screen and present, and we'll just be recording in the background.
absolutely. So being a teacher in front of a class is easier than this right now. But I'm going to share my screen with you. I'm going to go over my current existence, if you will. My current existence is, again, as a CNA. And yes, there is no easy answer to the issue and the complication of a nursing shortage. So I'm going to give you a little background, first of all, on what it is to be a CNA in the state of Illinois, or what it takes, and go from there with you guys. Just a couple little things. So as far as healthcare, we all know that it is a service industry. It is one of those industries that consumers are one of 6 of these things, and I've seen quite a few of them. First off, they come in, they're usually sick or injured and under considerable stress. They stay the night for care. Healthcare, some argue it's not a need, but it is a need, not a want. No one wants to be sick. No one wants to have to go to a doctor to get tubes and needles and things stuck in them. Services are provided intimately. We are most vulnerable, especially for women who've had children. You know what that's like. Have been pregnant, had a mammogram, had prostate procedures. Most documents that we fill out when we go to a doctor, they ask some of the most personal questions you can ever imagine. My favorite is, when was the last time you had sex? I don't know. But also care needs are, they're tailored to fit the injury and the illness itself. As well, services can be put, when you go into a healthcare facility, whether you acknowledge it or not, you are putting yourself at risk for additional injury, as well as additional illness. Unfortunately, healthcare related illnesses, MRSA, C. diff, horrible illnesses, but you are putting yourself in additional risk. And no one wants those for yourself or your loved one. As far as nursing goes, nursing hospitals are the largest employers of nurses, not the skilled nursing facilities, assisted living, none of those. It is hospitals. They're estimating within the next few years, 200,000 jobs every year. And this was from 2016 until then. However, there are others who estimate it to be even further on, 2030. Now, mind you, this was done in 2019 pre-COVID, this statistic. So those numbers have changed, considering the ebbs and flows, the retirements, people leaving because they don't want to follow policies, and things of that nature. Now, nurses themselves, again, all of you know, they fill many different tasks and jobs as nurses. So they're not just doing that direct care. So nurses take on case management, not just social workers, but they do case management. They become nurse educators, directors of nursing, they become teachers, supervisors, CNOs. There is a shortage now of nurse educators within most universities. If you go on to higheredjobs.com, there are, like, I believe, almost 2,000 jobs for nurse educators or some capacity in higher education. They're employed in all sectors, even with Amazon. Yes, Amazon they're looking for RNs. So now nurses are different from CNAs though. So as a CNA myself, I take on a different role. There are 1.3 million CNAs in the United States right now. The average age is 41 and they are female. The mean age, the mean wage they receive is $33,000. So we're looking at roughly about $15 an hour. Skilled nursing facilities, unlike with nurses, are the largest employers of nursing assistants. CCRCs coming in behind. However, we all know the CCRCs also can house skilled nursing facilities as well. They are the second, as well as general med surge hospitals are third as well. They start to distribute across clinics and other organizations, home health after that. The five largest states, or 5 states with the largest amount of CNAs, are again California, New York, Florida, Texas, Pennsylvania. Ironically, California, New York, Florida, and Texas also struggled the most with COVID. As far as the training goes to become one, I'm going to touch on this a little later as well, but for now, this is basically what you would need to become in the state of Illinois to become a CNA. As little as 4 weeks, I'm going to then be taking care of your grandmother, your grandfather, your disabled family member in 4 weeks. So that means I must understand their dementia. I must understand their changes in their moods, how to care for them, 4 to 12 weeks. 40 hours of clinical training, that's basically 1 week. So you are literally taking care of someone's parents or learning to take care of them physically, hands-on, 40 hours. If you are a nursing student, you can complete a fundamentals of nursing course, which is 101 basic. If you have foreign nursing, the equivalent of a registered nurse, a licensed practical nurse, you can come here and become a CNA. You must have no violations of abuse, neglect, no crimes on your background or specific crimes on your background. And you definitely have to pass a drug screening test. Now, with that being said, I just want to talk super quickly about what drew me into this. Well, first off, of course, the million years of experience I have in aging, but in the academic setting. My husband in 2020 was hospitalized in ICU with COVID. He did almost die. And up until that point, for me, CNAs had not been really at the forefront of my thought when I thought of healthcare. It just really wasn't. In truth, I know some of you, Applebaum, Kennedy, Straker, you guys have had some research experience with it. You've looked at this topic. Myself, it was never really like drawn. It wasn't until my husband was in ICU and he suffered with ICU delirium. You're talking about, this was the beginning of COVID, and they couldn't get CNAs to stay with him. And he had to have someone watch him. The nurses were off. They were struggling. They were trying to keep up with every other person dying on them every other second. They were trying to keep my husband alive. But the CNAs were the ones who actually sat with him. When he was in rehab, again, the CNAs. So up until the point of him coming off of the respirator and out of sedation, I spoke with nurses and doctors. After that, doctors and nurses were kind of limited, and it became CNAs that took care of him. So that was kind of where it started at for me. I knew the demand was there. I really wanted to get into healthcare, and I knew I wasn't going to be a nurse. It was not going to happen. So I said, you know what, I do want to become a nursing home administrator. And I felt like for me to be able to um, serve my people underneath me, I needed to be able to serve. I needed to be able to understand what they went through. And again, I wasn't going to become a nurse. So I went and filled in a sort of a gap. I became a CNA. April of 2020, I started the program. July, I passed the test. August, I started my training for nursing home administrator. October, I started working as a CNA in that order, and has been working since, off and on. I don't do it every day. I don't do it all the time, but I do pick up shifts. Currently, I am working at a long-term care acute hospital, um, and it's a beast, to say the least. Vents and um, feedings and people very, very sick. So the acuity is high. So as such, my experiences as a CNA have been varied. I've worked at skilled nursing facilities. I've worked at assisted living rehabs, and in some cases, all three in one facility. So I've had the pleasure of being able to see a lot of this. Well, I don't know necessarily if it's always pleasure, but a learning experience. And I've learned a lot from being a CNA. And I believe, truth be told, I believe every administrator needs to be a CNA because the job is taxing, it's exhausting. And over time, these are the four overarching issues that I find was, or I found were, or still, because I'm still doing it, it hasn't ended. This is a work in progress, but these four things are sort of the larger overarching themes that I found in doing this job. Workload, overload, that kind of team of one kind of idea. Cleanliness and infection control, big issue, big issue, massive issue. Employee dissatisfaction. I say dissatisfaction because dissatisfaction would imply that they're happy with what they're doing. And there was a lot of dissatisfaction. In oversight and managing, I think one of the biggest things is in a lot of cases, it is oversight and management that can reduce some of these other things that are occurring. And ultimately, all of them results in better quality of care for the residents and in the hospital's patients. All of these issues affects quality of care and patient outcome. And so with that, I wanted to start off by giving you a glimpse of what one day, an 8-hour shift would look like for someone. So in the state of Illinois, they can give us 15 residents. But just for clarity, we'll do 10 residents. So in an 8-hour shift, 10 residents. I got 1 hour for lunch and breaks. This is collective. If you get breaks, because there are days where I go without taking a break, I just get my lunch. 1 hour for meals, and this is for the residents, handing them out, feeding them for those who cannot feed themselves, picking up trays. Now, in addition to that, every day someone is getting a bath. You have at least 2 baths a day. So that's 30 minutes to an hour for 2 baths. More likely 1 bath because someone will say, I don't want to get a bath. But at some point they have to get a bath. So you could have 2 residents having a bath, which again, anywhere from 30 minutes to an hour, depending upon their ability to assist you. So if you have someone who's contracted, who's unable to do something, you're in the bed bath. If you have someone who is able to assist you, you take them to the shower. When you take them to the shower, if they're unable to stand, they go into a chair. So then you are bathing them in this chair, washing their hair, giving them oral care, putting lotion on them. And if they're engaged with you, they'll let you know what they need done. So you're taking care of these residents for 1 hour. Charting, again, 45 minutes to an hour, depending upon the day. So that's an average of 4 hours right there alone, roughly. The remaining 4.5 hours are for answering call lights, changing and rotating residents. So that 4.5 hours, you're looking at 270 minutes for 10 residents, 27 minutes on average a day for each resident. And you're looking at 2 times a day, you need to rotate and change them. If they have feedings, meaning if they're a feeder on a feeding uh, machine, they then tend to go to the bathroom a lot more. So you may be changing them more than 2 times a day, but on average, we'll say 2 times, rotating them at least left or right. Every 2 hours, you're doing this. So we're breaking it down to about 13.5 minutes per time you need to change, rotate them. And this is just giving it for 2 times a day. If you have to do it more, that goes down even more. So when we look at an 8-hour shift, it's a little difficult. And again, this is all dependent upon how engaged a resident is. If they're not combative, it puts on a different layer. If they're sundowning, it's a different layer. So those 13 minutes can go very quickly, and you'll need more time to do that. So that's just one day of doing this, and this is just an 8-hour shift. So the workload is heavy, and that's for 10 residents, and that's one CNA. And I'm not I don't want to say I'm going to beat up on nurses, but nurses, I've had instances where they just tell me that's not my job, and I've been on my own. Now, mind you, if I have a bariatric patient who is over 250 pounds, I'm small and scrappy, and thank God I am. But it takes on more. I've had injuries doing this job. So it's not as simple and cut. Another issue I found was the cleanliness and sterilization. So not all facilities are dirty. I don't want to make that as a clear that they're dirty. They're not. My first experience seeing it as a CNA, and this is the very first job because I work for an agency. I work for, well, up until this position, I worked for an agency. And I would go out to different locations. And I got the opportunity to see different locations and how they handle their cleanliness, their environmental services staff, and things of that nature. So when I say facilities are dirty, those are the ones who have a lack of environmental staff. They're not cleaning the facilities. They're not sterilizing the central areas that the patients and residents are located at. And they're sitting there for hours. I've had to take residents to bathrooms that were bowel all over the floor and the wall, and I was scared to touch it. And it was amazing to see this, and I'm thinking to myself, oh my God, you're taking care of someone's parent or grandparent. And then in regards to failure to source out adequate environmental staff, a lot of facilities, in order to save money, they were not hiring staff. And also they weren't able to find staff. People just didn't want to work and don't want to work in some cases. But there are other factors for why they absolutely just quit. Change of guard, you know, not having enough staff to help them is what made them leave, which some of you already know. Again, these are issues that are well documented. Sharing of food from one resident's plate to another. I've seen that happen, and that drove me crazy. I was just like, no. But that kind of cleanliness and having things be sterile to prevent infection, the transmission of disease, COVID. Again, common areas weren't sterilized in a lot of these places, meaning I didn't see someone come along with a disinfectant spray and cleaning down tables once they were done eating. I know this is weird, but for me, it was a big thing because if you look at nails in the nursing home for patients and residents, some of them are super built up with skin and decay and bacteria. And a lot of times the hands weren't being cleaned before they ate, and they weren't being cleaned after they ate. Residents aren't wearing masks, or they weren't wearing it properly. And this is at the start or the midway through COVID in 2020. I was at one facility where I was doing my training, my clinicals, and The residents were corralled, and I'll talk, at the bottom, they were corralled around the nurses station, didn't have their masks on, or they were underneath here. And again, it's very difficult to have someone with dementia. You're constantly pulling their mask up. You would be doing that all day long. But at the same time, 6-foot distancing wasn't in place. Again, hand washing wasn't in place. So it's only understandable why 30% of the deaths occurred in nursing homes. Protocols were just not being upheld. And it's disheartening to see. So again, corralling at the nurses station, again, because of a lack of staff, they can't, and you have these individuals with these chair monitors or these chair alarms. You have these individuals who constantly want to get up and down, just randomly want to get up, and then they sit down. They randomly want to get up 5 minutes later. So they have chair alarms. So unfortunately, in a lot of cases, if you don't have enough staff to monitor those types of residents, you are going to have to put them in a central location. And a lot of times, unfortunately, it is located around a nursing station or close proximity to a nursing station, which can be problematic. Again, reduction of disease, infection, problematic if you're having them sit in a central location and there's no separation between them. But again, shortages central to this issue. So my favorite one is the dissatisfaction from employees. Poor pay. The average pay in Illinois, or for actually through the Bureau of Labor Statistics, they say the average pay for a nursing assistant is $15 an hour. In certain southern states, it's $12 an hour. In places like California, New York, it's higher pay, about $16 an hour. But poor pay is definitely a reason why, and as you all know, why they don't stay permanently with a company. Now, mind you, it isn't to say that they're not working. They, like me, go agency. And they work agency and make $3, $4, $5, $6 more. Or they go to a hospital and they make $8 to $10 more. And then do a shift differential. So it is more so that they just don't go on permanently with the companies. They kind of freelance. Absenteeism, huge. It's not just that they don't want to work and taking on full-time jobs. They call off of work. They're like, I'm exhausted from the last 3-4 days that I've worked. I've had to fight the same resident 3-4 days. I don't want to go to work. They call off. So absenteeism is huge as well. Not respected and or not heard. I can attest to that one myself. I can attest to, I had a situation where I went to a nurse, and CNAs are the eyes and ears of nurses. And so I went to a nurse when I was doing my rounds when I first came in, and I had been taking care of this one resident. And when I went in to visit them, they were slumped over in their chair. It wasn't unusual for them to be a little bit slumped over, but this was, I asked them, are you okay? They said they had pain, they were clenching their teeth, their jaw was hurting, and they were slumped over. My fear was this person had had a stroke. So I went right directly to the nurse. I was like, you really need to go check on this person. I, oriented her to 3 with the mini mental status exam. She didn't remember 2 of the words, but they were like, oh, it's common for her baseline. I was like, I had to fight with them. And I finally just said, I just need you to go look at her. Tell me if I'm wrong. I don't care. If I'm wrong, I'm okay with that, because I'd rather be wrong than right and something happened to my resident. So, and I take it personal because I got to know my residents, and this person I knew. And so I was like, please just go check on her. Went in the room and they were like, yeah, something's not right with her. But again, not being heard, not thinking that a CNA has the capacity to say, hey, something's not right, because you're a nurse and you give medicine. I take care of her more often than you do. You go in there, you give her medicine, you see her floating around, but I actually take care of her. So listen to me. The physical wear and tear. I had a resident fall on me and hit my knee. My knee was in pain for probably a month afterwards. And this was a heavier set resident. I went to take her to the restroom. I had her standing up. She was perfectly fine. Within seconds, she was like, I gotta go. And she literally started falling and took my knee with her. I had another resident fight. I mean, literally was pulling against me. He was pulling one way, and I'm trying to keep him this way because he wanted to go on a vacation. He literally wanted to go and leave. He was like, I'm going. I got to go to my mom and dad. And we were like, no, you can't leave. And so I'm holding the chair, and he's pulling this way. My elbow hurt probably 3 months after that. So again, injuries, the wear and tear physically on these individuals is immense. Um, and again, that unwillingness to help from nurses. And I'm not saying that they don't have their own tasks to do, but it was just overwhelming when you're like, I just need you to come help me do one little thing. I'm not asking you to help me bathe the person. I'm asking you to help me turn the person, do X, Y, and Z. Very difficult when you don't have a collaboration between nursing staff as a whole. This was the fun one. I was physically assaulted by a 90-year-old. Fantastic. She became combative as I was changing her, and she clocked me. She just right on my jaw. I was like, man, she had a good little left hook too. She hit me, she scratched me, and literally I was just trying to change her. And so, as well as the one resident who was trying to pull away, it's not on here, but it's also the terms that are used. I've had a lot of residents, not a lot, there's a few instances where the N word was passed freely. I have been called colored. I'm like, wow, I didn't know they even used that word anymore. But even just the accusations of theft. On my first day at one facility, one of the nursing aides was so upset because, and I watched her, she was just mad. But it was understandable as she explained what happened. So another aide, she came to the aid of another aide because that aide was being accused of stealing. And she herself had been accused of stealing. And so she felt this kind of like she needed to vindicate this young woman. She needed to stand up for her, stand up for every CNA like that. And so she just became enraged and so angry. And it was understandable. So they had to take her away from the area, which was the assisted living facility area, and put her in the SNF area, the skilled nursing facility area. So again, things that are mentally abusive and physically abusive. And again, the idea of compassion fatigue, this sort of accumulation of trauma of constantly taking care of someone and seeing someone die. You know, I had one patient who, I'm sorry, resident in this situation. Patients are where I'm at now at the hospital, but one resident, he was a priest. He was dying, sweet. Oh, I loved him, loved him, loved him. He was so sweet. And I was gone for 3 days. And when I came back, he was starting to deteriorate. He was starting to literally decay in the bed. He wasn't eating, wasn't drinking. His face was emaciated, body, bones, the screws in his back were starting to poke through. He was dying, but he wasn't dead. And we watched him die. Those things are hard. So when you care for someone, and I know part of the CNA program is that you're not supposed to care like that. But again, healthcare, it's got care in the very word. You cannot do this job and not care. You cannot do this job and not get compassion fatigue if you're actually caring. And so yes, that is part of the dissatisfaction, this cumulative trauma that exists for these CNAs. Oversight and management, that was another one that I saw was really important, was because not all nurses are management material, but they must supervise us when we come on shift. So my RN has to tell me what to do. She has to supervise me in addition to doing her job. Um, and not all of them know how to manage. All of them have people skills. Uh, and they're overwhelmed by their job and ours. So you're asking them to do their job and ours is basically what it is. If they have to tell us what to do, to a point, not completely, but to a point. Agency workers, which a lot of these organizations are working with agencies, but they don't always chart. So there is a discontinuity in patient care. If you're not charting, even though the nurse is supposed to do it, the nurse isn't, again, it goes back to that oversight. If the nurse isn't getting a report from you, and I've seen it happen, how do you know if they had a bowel movement? Oh, 2-3 days go by, they haven't had a bowel movement, even though they changed them and had a bowel movement 2 days ago. So agency workers need to chart. Every agency worker needs to chart, or they have to give report, because even when CMS and IDPH goes into these facilities, they're looking for charting, they're looking for documentation, but unfortunately, it's not always there. Boards and stakeholders are concerned with profit. Not everyone, but the current facility that I'm at the hospital, the CNO said, well, the board said to do this, and you all have the right to do it now because the board said to do it. It's because they want to get to CMS's 5K status. And for those of you who already know, the 5K status really puts them at a different level. They also pushed it as, oh, well, if you guys do this, you'll get a bonus. So we push patient what you need and what the board needs versus what the patient needs, is what I took away from it. So unfortunately, the boards and stakeholders do push a lot when it comes to the care of patients, when it comes to profit. If it means I can save money, I'm going to reduce the number of staff I have to make it look like I have profit. The other day, I worked at the current facility that I'm at, and there were 30 patients. This is an acute facility. And this is like ICU or med surge, kind of a step down from ICU, med surge. And I had 15, close to 15 patients by myself. I said, how do you do that in an acute setting? There's no way that they're getting proper care. And technically, I saw some issues. So one patient had a fever, and I went to tell the nurse, hey, one didn't have on, the same one didn't have on his Texas catheter. So it's a type of catheter. I was like, well, he doesn't have his catheter on, and his family was in a room with him, and they were like, well, why doesn't he have it on? True enough, he wasn't urinating, he wasn't having any output, but simply because he didn't have any output at that moment didn't mean he wasn't going to have any. The nurse said, oh, it's okay, he's not having any urine output. Literally is what she told me. I said, oh my God. I couldn't believe it. I was like, wow, his family is asking for you to put one on. And she's like, no, it's okay. I was like, okay. I couldn't do anything about it. I had to go with what the nurse said. Corporate culture kind of goes back to the board and the stakeholders. Now, training not being enough. There's not enough training that they're having. I think, again, those nurses need more training in management skills, so that they can manage the situations better. They can manage how the CNAs do their jobs and their oversight. I also think when it comes to training for CNAs, there's not enough. And overall, it's just care is missing from healthcare. So when I see these things, these are the big overarching pictures of what I've been seeing with this. Now, management is important to me because I feel like management sets the tone for everything else. I've been doing research, and it's for my management courses, of course, but this stuck with me. Mayo Clinic, their core values, they got it right. The brothers started the facility, their clinic, with the hopes of caring for people in the community, the small clinic. they thrive based on word of mouth, their history of caring for people, their commitment to people, their commitment to service. These are their core values that they've created over the years. There's basically 6 of them. And all of them except one is just continuing. So establish a precedent and continue to do it. The ideal of service and not for profit. You know, concern for care and welfare of others. It's gotten taken out of healthcare a little bit. And I'm hoping somewhere along the line someone actually brings it back into it. But it has been taken out of it. But they're not only concerned for the welfare of their patients, but for their staff, the professional development, for continued change, working towards excellence, and absolute integrity. I put those there because I feel like they're so important and they're missing in our system now, and that we need to get back to those very core ideas. So in order to change it, I believe some of these things need to occur. There's a book out there that's noted as saying patients are second. I found it fascinating because they really did focus on their teams and really helping their teams to grow and really increasing employee satisfaction. One of the things I believe needs to be done is that there can be or should be no more than 10 residents per CNA. I just don't believe it. Especially when you're dealing with an 8-hour shift, which most CNAs do an 8-hour shift. As I broke it down earlier, there's just not enough time to provide that quality care that they want and need. If I have a family member and my CNA is running all over 15 residents, how is that person giving enough care to my family member, to me, to my husband? It could reduce some burnout and compassion fatigue. I myself believe when I do work with 10 residents, I prefer 8, but 10 is okay. But you're getting past that, it's just too much. I've spoken with other nurses who say the same thing and say CNAs who say the same thing. It's too much when you get past 10. Just because you can do it because policy says, oh, I can give you 15, doesn't mean you should. Empowering teams to complete skills together. I think one of the things that happens in these facilities is CNAs over there, nurses over there, CNAs over there, CNAs over there, and they're not working collaboratively. I've worked in facilities where I've worked in a team environment with another CNA, we've gotten both of our jobs done faster and we've provided the proper care. But we're working as a team. Right now, again, it's that team of one kind of feeling. And increased hourly wages. Truck drivers make $22 an hour on average. CNAs make 15 in the state of Illinois, 12 in some other places, 16 in California on average. And the biggest one for me is focus on continuous training. One of the things for me is when you have 4 weeks of training, that's not enough. They only barely sort of breeze by dementia. They breeze by these illnesses that are occurring in the nursing home. They don't really even talk about C. diff very much. They don't really talk about it in depth about, MRSA. They don't talk about the type of care that people should really be getting when you're in these training programs. So I think the CNA requirements need to be 12 weeks of training, 2 weeks of clinical training to be federally mandated. I believe with doing the training, doing the job, I think there's more, but I come from a background in aging, so I understand a lot more versus someone who may have a high school diploma and is like, well, I'm gonna go do this job because it's 4 weeks of training and I can come out and make $16 an hour. The level of knowledge that they have is bare minimum. And I think for them to be able to understand someone who's going through sundowning, it needs to be a little more nuanced. They need to experience it for a couple weeks. But I think because the need is so great that 4 weeks is like, okay, let's just get them out there. We just need them so bad. But I don't think it's enough. In the facilities, they need to have it where all of them have access to skill reviews. because even the most seasoned CNA forgets how to do something. Even a nurse. I was at this care facility, and the nurse was in the room with the resident, not the resident, but the patient and the family, and literally she didn't know how to put together a machine. I was like, wow, I couldn't even imagine if I was her family watching this woman have to look into another room to figure out how to put together something that's going to be a part of my mom's care. It was hard. So skills access and things of those nature. Management makes the difference. Again, they need more management courses. We need advocates for human profit and not growth, not just human profit and human growth. Follow Mayo's lead, be of service to your residents and patient. Lead with understanding. Focus on employees' happiness as much as you do on your residents and patients, and bring care back to healthcare. It's that simple. At least to me, doing the job and having the aging background, I believe those are the things that are most important. But I know I went through it pretty fast. But yeah, that's where I am. So yeah.
So thank you, Jackie. So let's open the floor for some questions. I am very passionate about this area, so I'm very curious. I know there's several others on the call that might have questions. You can feel free to unmute and ask, put them in the chat. Thank you so much. This was really, it's so cool the work that you're doing to really get in there on the ground and really see what's going on. Truly, it is. Angela, I see your hand raised.
First, a compliment and then a question. That is like phenomenal that you are willing to do that you still care, that you have not checked out with compassion fatigue. I just want to compliment you. I've heard of this before, but I haven't, the way you've analyzed it, I haven't quite heard it done that way. So thank you. You really have opened up my eyes. So my question is, what are you going to do with all of this other than write it up in a professional paper? Do you see any practical application for what you're discovering? Because I do.
Well, a couple things. I know in the state of Ohio, which actually, just to give kudos to Miami University, as well as the state of Ohio, when I was there at Miami, they actually had someone come in and speak, and he was going through the administrator. I think he was going to be an administrator in the state of Ohio, and he actually had been a CNA. So that's actually what inspired me to do this, not just my own experiences with my husband, but it was because I learned it through Miami. I had that moment where I saw it in action with that person as well. As far as what I plan to do with it, my goal is not just necessarily to type up a paper and put it out there in the universe. My goal, and I think Applebaum has done this, Kennedy, I've read a paper that both of them have done together in regards to, and they've looked at this topic as well. The kind of burnout that happens, what's going on. My own experiences though, I'm hoping to use them as an administrator. I'm hoping to do the job. And it's needed for me, it's needed. I think the job is heavily in demand. But I also think that it will help me to, I guess the statement is, I'm a person who believes in order for me to lead, I need to serve. That's that old statement that's out there. And I believe I'm going to be a better leader because of it. That's at least how I feel. So it's going to be an actual application of it going forward. So it's going to help me to do my job better. So, but what is your view? What are you thinking? Practical application.
So, the first thing that came to my mind immediately is a training program for nurses. I would be connecting with some of the national nursing organizations and maybe some of the national medical organizations and sharing some of this data and seeing if they wouldn't sponsor you to create training programs. I know that there are some that are based on some stuff kind of similar, but apparently we still need it because you're still finding it.
And
So
I think one of the things though is that I don't know if it necessarily needs to be that, but I think it definitely needs to be incorporated into the nursing programs a lot better. I think they need to add in a course on management for them to take. I think it needs to be that and some nurses, just like administrators, have to take it as part of a requirement for them to become a nurse, but they do it and that's it. They're done. They take the course, they get their clinicals, they get the certificate, and they're done. They don't do the job. A lot of nurses are clueless, really. They don't do the job. And so I don't know if they have that kind of perspective of what a CNA goes through. But again, a CNA doesn't have the perspective of what a nurse goes through. So I think that, again, it needs to be a collaboration between both because they are a team. There's no I in team. Oh my God. But it needs to be a part of the pattern. And again, I think the CNA needs to be extended out. 4 weeks is just not enough for you to be able to take care of someone's parent properly. Care, yes, but to understand what you're doing and why you're doing it and what's happening at 5 o'clock, 3 o'clock, I swear, when you read about it in theory, you're like, oh, okay, sundowning. When you see it in reality, oh my God, it's a different beast, a different beast. They start screaming, they get up from their chairs, they start yelling at you, they start hitting you. One resident was beating she was a beating, but she was taking her walker, lifting it up and hitting the CNA. I mean, it just was like, I'm like, oh my God, you see it in reality and it just becomes solidified in your brain. I will never forget this experience, ever. Ever. So yeah. And I would suggest, just as a note, if some of your students, you guys, if they are considering going this route at Miami, I know they used to have that business program at Farmer. Tell them to take some classes, in business, and maybe you guys meld something together to get it to where, there's a program for nursing home administration at Miami. So, because it's needed. And it needs to have more people who are passionate about it, not just, oh, I'm going to go do it. Because in the state of Illinois, really, I can be 21 years of age and have no background, take a course and become a nursing home administrator. I can make 80 grand a year, but I have no passion for it. So I think more people need to be involved and engaged. Yeah.
Bob, did you have a comment?
Yeah, so I just, one comment and one question, and yeah, again, thank you for this work. And you do, combine two really important areas. And I would encourage you, as Angela says, to think about training, that kind of stuff. So two things. One is, in Ohio, you're talking a lot about 4 weeks. Ohio, it's basically 2 weeks.
Wow.
For, because that's the federal standard is 80 hours. So 4 weeks is, hey, that's a luxury. What I was going to ask is, we've been doing a lot of work on trying to address this topic from a research perspective. And I'm just wondering if there was one thing that you would name to help with retention of CNAs, what would be your number one piece of advice for agency to help retain CNAs?
Well, money is definitely the biggest one. I can't even say past, because when I talk to a lot of people who've done agency or are doing agency, they're all like, oh yeah, I make more money doing this. Oh, I make more money doing that. Even the nurses, the same thing. I'll make more money. PRN, they can shift around. There's no commitment to organizations. So find a way to connect with the CNAs, your nurses, and build a rapport, even if they're agency. Poach them. but build a relationship, get to know them, get to say, hey, how's it going? How's it doing? You know, talk. I worked at organizations where I've never known who my administrator was. I barely saw my director of nursing. I don't know you, you don't know me. We don't know each other. There's no commitment for me to stay. Connect with me, get to know me, get to know what makes my life the way it is. And I think a lot of CNAs would say the same thing. Is like, there's no commitment to these organizations. So find a way to build a community within them. And I know that sounds weird, but management of your staff is super important. So management really has to be key to this. It really is management. I really can't say it enough. They're the ones who bring in staff. They're the ones who fire staff. They're the ones who acknowledge the relationships they have with people. They're really, really key to this. Management is really key. And management style is very key as well. You can't be a dictator. And you can't. When someone has to, first off, care work is care work. And being a dictator to someone who's caring, it doesn't mesh. It doesn't mesh. You have to change as the person says, the culture comes from the top. Absolutely. It comes top down. If you show that you care about your workers, you're committed to them, whether you make $16 or $15 or $14 an hour, but if you show me you care, because literally I went from making decent money to doing this job, and I make no money, but I know what I want to do and my goal. And so I took a very big hit and I was like, I'm just going to do it. And so it is top down. I think personally, I believe training and top down, those are the two key components. Because outside of money, that's something that's budgetary. And again, that's management and board as well. But again, you know, I've read articles, and I think it was the article you were in that talked about how there's been an exodus, a mass exodus. At the same time, there was negative in the organization. And then you have organizations that have great management, but somebody may have poached them. So really, I think those are the things that I would say the most. So.
Thanks, Jackie. We just have just over a minute left. Wasn't sure. Bob, did you have another comment or question? Okay. I didn't want to cut you off. There's several things in the chat. I want to make sure you saw it, and I can send you the chat afterwards, Jackie. But Diane made a comment, such an interesting presentation, and thank you so much for all your good work. Question, what would you recommend as the best tactic to advocate for change? Unionization of CNAs, state policy lobbying, federal policy lobbying, health system lobbying, continued research and dissemination, and so on. And I don't know if you have any insight on that. We've got about a minute left.
Well, that's a great question, because I did work at it. I didn't work, but I did an interview with an organization in the northern suburbs here, and they had a union for the nurses, and they were much better off for the CNAs. They didn't have it for the nurses, but they had it for the CNAs, and they had a better retention with the union. They paid their fees and they stayed, and they had a better pay rate too than the other ones that didn't. And this is like a corporate organization as well. So it's like it had different locations. Some locations had unions, some didn't. And the ones that had union had better care. Their employees were happier and had better pay. So I would say union is super important, but a lot of unions are being faded out now. So I don't know how that would factor in for the CNAs unionizing. I think definitely policy is a big part of it, education. And someone wrote about culture, changing the culture in which we exist within. Again, when you have COVID, and I'm just going to be very quick about this, when you had COVID and you had nurses coming out and sitting on the ground, putting their heads in their laps and crying because they have patient after patient after patient after patient dying, they have no resources to go to and to call, and they're caring for people. We need to change the culture of healthcare. It needs to start caring more about the people in it and the people they care for. So I think policy, changing the culture that we exist within. So, and it starts from top down, and I'm hoping that I'll make a change. I'm hoping.
Awesome. Well, Jackie, thank you so much. This is a really great presentation and conversation. We're grateful for the work that you're doing. What I'll do is I'll share the chat with you afterwards.
I see hands too, and I'm so sorry,
Yeah.
everyone. I'm so sorry.
This was great. This was perfect, Jackie. Thank you so much.
Oh, absolutely. You guys, thank you. Good luck to all you first years. You're in the best hands with all of them there. Absolutely great people. If you ever need to reach out, she has my email. Definitely reach out to me and I can give you any advice I can. I'll try.
Thank you, Jackie. Thanks everyone for coming.
Bye. Bye, everyone.